Well, thank you very much, Ronnie, and again, thank everybody for having me. Before I talk about hypertension and the low-tech side, let me just say I'm one of the old dogs that Dr. Wagner talked about. While I have not taken his course or participated as an individual, only because predominantly of my age, although if I were probably going to practice for another 10-ish years, I would certainly do that. I have attended the clinics and seen patients side by side with Dr. Wagner. And I have to tell you that I was an absolute nihilist when I started, as many of the more senior physicians at USC, particularly in the Department of Internal Medicine. It's extraordinary what Dr. Wagner has done. I am actually a recipient of Dr. Wagner's skills. One morning, and this is not a HIPAA violation since it's May, I just woke up and I just had this terrible cough and I had this extraordinary chest pain. And I put up with it and put up with it and put up with it. And finally I'm attending with Mike on a Thursday afternoon, seeing about 30 patients in our low income clinic. And I finally said, Mike, it was the end of the day. I said, Mike, you got a couple minutes? Would you put your echo right here on my chest? This is killing me and it's not getting any better. Now, I didn't have a rib fracture, but I had a whopping hematoma around between the ribs, and it's extraordinary what he's done. And that was only just really scratching the surface, so I really recommend all of you to pay attention to the field, even if you're already specializing in doing echoes in certain specific areas. I'm actually reasonably okay in cardiac echocardiography, because I grew up with that and in the hypertension world, but the other areas that you can apply echo in our practices, whether it's women's health, or female patients, or a general medicine practice, it really does not matter. It's everywhere. Big toe echo is probably coming next. Mike, thank you very, very much. Well, a couple days ago, I told you that I went into hypertension because I thought it was easy, and I thought it was going to be very non-controversial. I mean, what in the world could be so hard about your blood pressure is elevated, you have an elegant, cheap modality to measure it that's reliable and accurate, and all you have to do is lower it, and now we have a plethora of effective, safe, and actually very, very well tolerable, with mild exceptions, antihypertensive medications. I said, this is the field for me. And 25 years later, 30 years later, I never imagined how much controversy could surround treating hypertension, detecting hypertension, and managing hypertension. And really, I'm actually sad about this controversy because it should not be occurring. It's too straightforward, and it's not worth the argument for smaller areas of the area of hypertension. And I do not want to cloud that argument and that controversy in our general practices of treating the hypertensive individual. So let me spend this next hour, hopefully slightly less than an hour, talking about the controversy, where we've been, where are we now, and where we're going. And I'm hopefully going to put I'm actually going to say the C word, some common sense into what we're doing. Because I really think we've heard too much noise, and there's been too much controversy over what blood pressure level should you treat, who's hypertensive, who's not hypertensive. We're better than this, and I think we can make it simpler than this. Where did the thing go? Give me everything else but the advance. Is that it, Ronnie? Right there. Yeah. Oh, here, I got it. Thanks. Thank you. Yep, I had the pointer, but that's not going to make the next slide. Again, you've seen these disclosure statements through the week. And I will be talking about some of the data from our Pan American Health Organization and World Health Hypertension program. But obviously, I'm an advisor to both organizations. So what are the objectives of what we'd like to try to accomplish? First of all, the major controversy came with this set of guidelines, the American College of Cardiology, American Heart Association 2017 guidelines. So certainly let's look at those guidelines, compare and contrast where we've been and where we are presently with other competing, if you will, or dueling guidelines from other organizations. But more importantly, look at the clinical studies that led to changes in proposed guidelines, some of which I'm going to even say for the hypertension world are pretty radical, and also determine where we should be now in our general clinical practice. What pieces, if any, all, or none of these hypertension guidelines should we put into our clinical practice, because we all want to give the best care. And again, starting Monday morning when I go back, that's my intention, and obviously that's what I want to do as a practicing physician and healthcare provider. But these are the questions I think that are necessary that we at least ask ourselves and we try to address. In other words, what are the major changes in the new guidelines? That's rather easy. We can just read them and assimilate them and talk about them and discuss them. But more importantly, what's not as easy is what is the evidence behind the guidelines? And by evidence, I'm talking about clinical studies. Is the guidelines based on evidence-based medicine clinical studies? Is it based on expert opinion? Or is it just based on what I'd like to think it is, or what I'd like to think it can be? These are real serious concerns when you're a member of a guideline committee, and you have to put all three of those into the thinking process. What are the major implications of the new guidelines on our population, healthcare systems, we in our clinical practices, and more importantly, the patient? And should the guidelines be adopted? All of them, some of them, none of them, and if so, why? What's that decision-making process that we should go through? I like this cartoon. Dr. Piziak's seen this cartoon many times. All of my cartoons come from my mother-in-law, who lives in Houston. And she clips them out and puts them in an envelope and she sends them to me. Believe it or not, I still get them. So this comes from Houston, Texas, where she lives. And this is from one of the major Houston papers many years ago. And you can see the provider is saying, Bob, your blood pressure is extremely high. And Bob goes, well, whatever, I take everything with a grain of salt. And I've been looking at this cartoon for many, many years. It only struck me about 5 or 6 years ago that Bob not only has hypertension, which is what we're going to talk about today, but he has what Dr. Piziak has been talking about and others have been talking about throughout the week. He has central obesity, so he probably has either pre-diabetes or type 2 diabetes, hypercholesterolemia, accelerated atherosclerosis. In addition to his hypertension, he has metabolic syndrome. I hate to say it, but this was a lay cartoonist, so this is the average Houstonian in Texas. Houston obviously is one of the highest obesity rates as a city, only probably outflanked by one of our southern states and our southern region. Well, where are we now, and how did we get here? And I already mentioned that famous thinker, if you will, Yogi Berra from the New York Yankees, which he's coined all of these cliches. You can see a lot by just looking, and yesterday I mentioned you can hear a lot if you just listen. So what's been the general trend with our hypertension guidelines? The first thing that strikes me is the treatment, the management, detection, and treatment of hypertension has been basically one generation. Our generation. This is not 200 years old. This started in the late 1960s and the early 1970s with seminal clinical trials from our VA system, which demonstrated that even rudimentarily lowering the blood pressure significantly reduced cardiovascular outcomes in patients, in veterans in these studies with extremely elevated blood pressures. So this all just started in the 70s. But the general trend over the last 2 to 3, 4 decades has been, and if you look at the JNC guidelines, which have been the major program sponsored by the National Institutes of Health that have developed our guidelines until this year, where the ACC and AHA have taken them over, has been that the diagnosis of hypertension has been at blood pressures lower, 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 and lower. So then the treatment thresholds, when you start treatment, has become lower, 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 and lower. And by default, the blood pressure goal has become lower, 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 and lower. Until, and most recently in this slide, JNC 7, which was 2003, we hit a point where we now added pre-hypertension, recognizing that blood pressures of less than 140/90, this is diastolic, blood pressure, less than 90 if you will, are not benign, but we still didn't know what to do with them. And at the same time, with systolic blood pressure, the category prehypertension was added at systolic blood pressure is less than 140, also acknowledging that they're not benign, but yet there was no evidence-based medicine to support pharmacologic treatment of these blood pressures of less than 140/90. Clearly still, we've treated blood pressures greater than 140/90 with the goal of lowering the blood pressure to less than 140/90 in most individuals in the general hypertension population. So that was the trend, and that was JNC7. So when we now look at the newer guidelines, I'd like us to think about two separate groups, almost like dividing the Red Sea, because I do believe they possibly should be treated differently. One is the general population, the population that's younger, and again, you know my definition of elderly, but let's make it, say, 60, 65 years of age. The general population that's healthy, less than 60 years of age, is one population. However, there's another population that perhaps we should pay special attention to. Those that are older, greater than 60 to 65 years of age, individuals with high cardiovascular risk by whatever parameter you use, whether you use the ACC-AHA calculator, the Framingham risk calculator, but some determinant of cardiovascular risk, those that already have cardiovascular disease or at high risk for cardiovascular disease, such as Dr. Piziak has been telling us all week long, diabetes, and my nephrology colleagues well know patients with chronic kidney disease and end-stage renal disease on dialysis. I told you before I trained in Boston, and I did my hypertension training in Boston, but my first faculty position was in Pittsburgh, Pennsylvania, at the University of Pittsburgh, and I was young, this young whippersnapper, and I knew everything. There wasn't anything I didn't know. I was about 30 years old, 31 years old, 32 years old. I was already director of the hypertension program at one of the major hospitals in Pittsburgh, and I was the associate program director of the internal medicine residency program. Much too young age for any of that. And I asked the question, what's the best blood pressure in the United States that we should achieve for universal outcomes? You know, what's our target blood pressure should be? And again, this is in the early 1980s. I called the NIH. They didn't know. I called the American Heart Association. I said, surely these individuals know. I respect all of them. They didn't know. I called the Kidney Foundation. They didn't know. A new person moved in next door to me in my neighborhood, a new family, middle-aged family, and we went to dinner. They took us, my wife and I, to dinner. And he asked me, Don, you know, what bothers you? And I said, you know, I'm bothered by what's the best blood pressure to achieve in the United States? And he was the CEO of a major shoe company. And it took a nanosecond for these words to come out of his mouth. He said, Donna, you were in Boston, right, recently? I said, yeah. He said, what's the biggest building? What's the tallest building in Boston? And that was easy, the Hancock Building and the Prudential Building. And he said, have you traveled recently? I said, yeah, I just got back from San Francisco. He said, what's the biggest building in San Francisco? And I said, the Transatlantic building. Well, what are they? Who built those buildings? And it was clear, the insurance companies. He said, call the insurance companies. And I did. This is actual data from the insurance companies in the early 1980s that knew the answer. Why? Money depended on it. They have these huge actuarials, and they follow these actuarials verbatim, and they better be pretty close to right, because they're going to charge you more if you have higher risk and less if you have lower risk, and they have to get it right. And this was their data for diastolic blood pressure in the early 1980s. It was known, I superimposed the mild hypertension and moderate hypertension at the time, still with 90 and then 105 by the criteria in the 1980s, if you will. But they knew that your morbidity and mortality risk increased from diastolics of 70 on up, and it crossed the normative American, the average US American, at a diastolic blood pressure of 83. Amazing. So if you had a diastolic blood pressure greater than 83, you were at excess risk. If you were at less than 83, you actually had a little bit of benefit in terms of the total US population. So that was a clue. We knew to treat blood pressures 90 or greater, but we still didn't know what to do with this little sliver in here, which was at excess risk, and that's now the pre-hypertension group that we just alluded to in JNC7. And the plot's going to thicken as we get into JNC8 and then the new ACC-AHA guidelines. Well, it took about 25 years later for science to catch up with the insurance companies. The HOT trial asked the same question. What's the optimal diastolic blood pressure or to lower the blood pressure to in patients with hypertension? Reverse, not just the population now. You already got it. What's the optimal blood pressure to lower the blood pressure to? And long story short, in the hypertension optimization treatment study, the answer was, if you started at 105 and you stayed at 105 in terms of the therapy, you didn't lower the blood pressure at all, you had no benefit. If you lowered the blood pressure by 5 millimeters of mercury to 100, you see some benefit, and so on and so on and so on, until blood pressures of around 85 to 80. This is the general population. So what was the optimal diastolic blood pressure in this study? Since there was no difference between these two groups, fancy statistics determined it was 83 in the general population. Who would have guessed, you know? Who knew, right? But in any event, now we have we have evidence-based medicine and we have scientific medicine to demonstrate that that's probably the optimal diastolic blood pressure for the general population. Remember that first group we're talking about. And we have known this from the Framingham heart study and the Framingham heart calculator. This is a study by Vossen in the early 2000s, which demonstrated that blood pressures less than 140/90 are not benign. And this is a women's conference, a women's health conference. Women are equally at risk to men. There's no gender difference between these risks if you see it. If you look at the fold greater risk, in fact, it's greater in women than men. These are blood pressures that were deemed optimal, 120/80 or less, normal, middle pre-hypertensive range, and high normal, higher hypertensive range, but all of them connotate an increased excess risk from 120/80 or greater. As you can see, in women, it's 2.5-fold. In men, it's 1.5-ish, 1.6-fold increase. And that's that pre-hypertension range that JNC7. This came out in about 2001, 2002, and JNC7 incorporated this data into their report, 2003 report, and this is where the pre-hypertension range then came from. But we don't have any evidence, or we didn't have any evidence that treating those individuals, pharmacologically particularly, lifestyle modification is always the answer, but what about pharmacologically treating these individuals? There was no data to support whether to do that or not to do that. And so to date, we've been saying, no, let's not treat pharmacologically treat the pre-hypertensives. But there's been some data out there that alluded to possible treatment might help, but it's not good enough. But there were two studies. One was the trophy study, which was very interesting. This study asked the question, if you took pre-hypertensive individuals, blood pressures of 130 to 139 and 80 to 89, and you treated them with an antihypertensive medication, would it even lower the blood pressure at all? Because if they're rock normal, why would the blood pressure go down? And if so, what would happen to those blood pressures if you followed them for a couple more years? So what they did was they left one group on placebo for 4 years. Remember, that's appropriate therapy because there's no indication to treat these individuals pharmacologically. And one group for 2 years received an angiotensin receptor blocker. It doesn't matter what agent, but an agent to lower the blood pressure. And then they were placed on placebo for the next 2 years. So at 4 years, you had 2 years of treatment, and then everybody's on placebo for 2 years to just see what happens after you stop the medicine. This wasn't outcomes. This was just what happens to the blood pressure. Well, what happens to the blood pressure is very interesting. It does go down in the pre-hypertensive range when you treat with an antihypertensive medication. And very similar to our experience in our diabetics, in our pre-diabetics, the individuals that you treated for 2 years did not develop overt hypertension. In other words, their blood pressures did not go up over 140/90. In the placebo-treated group, they did. In the pharmacologically treated group, they didn't. And there was a 66% difference between the two groups. I don't know what to make of that other than if you lower the blood pressure pharmacologically in one group, it's going to take longer for them to get to 140/90 just as over that course of that time. But more importantly, remember, at the last 2 years, both groups were on placebo. But even 4 years later, when the treated group was on placebo for 2 more years, the blood pressures did not come back up to a significant extent and still stayed significantly lower, as if there was a memory effect on the vasculature of treating giving that 2 years worth of treatment. And that can be explained scientifically by vascular remodeling. You lowered the blood, it was abnormal to begin with, you lowered the blood pressure, the vessels were abnormally remodeled, and now under less blood pressure stress, they remodel back to a normal blood vessel. And it will take them a longer time to remodel back over time, so the blood pressure will rise eventually. And that would be the theory. But this does not allow us to incorporate any recommendations and guidelines. It's just sort of like food for thought. Well, my days in Pittsburgh, when I first got there, we also asked the same question at the time. And the data is interesting for a different reason. We asked the question for the first time, what's the best single agent to treat patients with hypertension? Is an ACE inhibitor better than a calcium channel blocker as single monotherapy? So we developed this study, treatment of mild hypertension study in the late 80s and early 90s, published in JAMA in 1993. Remember, we did it for a different reason. We wanted to know, was one drug class better than the other class? So you take mild hypertensives and treat them with just one drug and lower their blood pressure. One group received intensive lifestyle modification. We were hoping that that would lower the blood pressure because we were treating patients with blood pressures of 90 to 100, which we should have been treating them pharmacologically. But we convinced our ethics committees and the National Institutes of Health that this would probably lower blood pressure less than diastolics of 90, and it did. So kudos to sodium reduction and exercise and smoking cessation, et cetera. But on top of this, we treated 5 different groups with single drug therapy, just to see if one agent was better than the other. The answer was no, not one agent was better than the other. However, if you take these 5 groups and you combine them and look at outcomes, the blood pressures were significantly reduced in the treatment groups versus the drug treatment groups versus lifestyle modification, although lifestyle modification went down 10 millimeters of mercury. That's a huge amount. However, there was no difference in systolic or diastolic blood pressure between the 5 groups, but when you pull them all together, they had better outcomes. This was the first data that suggested that treating individuals in these pre-hypertensive range might connotate better outcomes, but it's not enough. It wasn't designed for this reason and obviously should not be included. This study did lead, though, to the ALLHAT trial, which was the major trial that followed our treatment of mild hypertension trial. I was the principal investigator of this study when I was in Pittsburgh. So, armed with all of that data, in 2003, the JNC7 committee said, in the general population, the threshold to treat is 140/90, as we all know, and the target to reach, the goal was treat the blood pressures to less than 140/90. Those, though, with diabetes, chronic kidney disease, the threshold remains the same, treat at greater than 140/90, but there should be a lower blood pressure target or blood pressure goal, and we should lower the blood pressure to less than 130/80. And we were under these guidelines for a long period of time. Virtually 10 years, or 10 or 11 years. There were societies that had differing recommendations, but these were our general practice guidelines, if you will. And then the JNC8 came along, and that was the next one after JNC7. The JNC8 committee met, and there was a big difference between JNC7 and JNC8. The JNC8 committee was absolutely told, use evidence-based medicine wherever possible, as opposed to expert opinion, observational studies, or what I wish should be true, but mostly expert opinion. When you do that, wow, the lay of the land changes because there's only so much evidence-based medicine. There's only so many clinical trials you can review, and they may not have been designed to answer all the questions that you're asking. And they did follow evidence-based medicine, and by doing that, they looked at the evidence they had And the guidelines dramatically changed. Their recommendations were, in the general population, similarly, the treatment threshold should be 140 over 90, and the target should be less than 140 over 90. But they now recommended that to include diabetics and patients with chronic kidney disease because, quite frankly, there was not evidence-based medicine to suggest otherwise. There was expert opinion, but there was not evidence. More importantly, in our older population, they went even further, and they raised the threshold level to 150 over 90, and the target to be less than 150 over 90, because that's what the evidence showed. The major trials in our older population did not achieve blood pressures less than 140 over 90. So how can you recommend less than 140 over 90 when they didn't achieve those blood pressures if you're going by the evidence? So what happened between JNC7 and JNC8 for these drastic changes? Almost a regression, if you will. Evidence was used, and they stuck to the evidence as opposed to, as much as possible, expert opinion. And that may have been too rigorous. So now, after JNC8, new data became available, particularly this trial, the SPRINT trial, which has gotten a lot of publicity. It was a trial in hypertensives. There was one ongoing in diabetics, which we'll talk about, that looked at intensive blood pressure control versus standard blood pressure control, and would it make a difference? And the protocol went like this. The standard therapy was under the JNC7, and in actually even guidelines, treat blood pressures greater than 140 systolic to less than 140 systolic. That's standard practice. The intervention group was intensively lower the blood pressure. This was based on systolic blood pressure to less than 120 millimeters of mercury. The inclusion criteria were patients at high risk, however. This is not the general population. It was individuals that were greater than 70, as you're going to see next. The average age was 68 years of age. So this was a distinctly older population, and it was done on purpose. They were already hypertensive under treatment, as you're going to see, and they had to have one additional cardiovascular risk, including advanced age or older, greater than 75 years of age. So this was a very high risk patient population that already largely had hypertension. Our site at the University of South Carolina did this study. We know these patients. We contributed a significant number of these patients to the study. We also excluded stroke and diabetes. Stroke because we already knew you should lower the blood pressure for secondary prevention of stroke. That would be unethical. And also diabetes was eliminated because there was another study ongoing, almost the same design, the ACCORD trial, which we'll talk about. The other thing that I think you need to know about the SPRINT trial was these patients had to be adherent. They already had been documented to take their medications. That is not our practice in general. So this was a very select, high-risk, adherent population. Highly motivated. They were more motivated than we were to be in this study. And here's the demographics. As I already mentioned, they were older. 60, almost 70 years of age. They had high cardiovascular risk, 20% by Framingham scores. They were already taking antihypertensive medications, almost 90% of them, and the average they were taking was already 2. We talked about fixed dose combinations. These patients were already on 2 or more antihypertensive medications. And you can see their blood pressures were equal between the two groups, about 140 systolic. Well, can you lower the blood pressure intensively in this patient population? Maybe you can't even do it, no matter what you do. And the answer is yes, you can. If you add enough medications, you increase the doses of medications, use the appropriate classes of medications, yes, you can lower the blood pressure. The standard treatment blood pressure, remember, was to be less than 140. They were already 140 or less when they started. So they stayed at about 136, 137 during the course of the trial. And of course, the intensive treated group did reach systolics about 121. The goal was less than 120, but this was good enough. This is what we achieved. So about half of them were less than that, half of them were more than that. But obviously the protocol was a success. And obviously the big news was there was a huge difference in outcomes between the two groups. This is the cumulative primary outcomes. There was about 25% reduction in the intensive treated group versus the standard treated group. And we were even surprised by this data. There was a significant reduction in all-cause mortality. We've only demonstrated mortality differences in our elderly populations, our older populations. We've never demonstrated differences in mortality in our shorter-term, younger population hypertensive trials. So this was really eye-catching. But where did these primary outcomes come from? These were the primary outcomes: myocardial infarction, acute coronary syndrome, strokes, heart failure, and death. They almost all came from heart failure-related outcomes. Heart failure was significantly reduced by intensive lowering of blood pressure compared to the standard group, and probably connotated to the reduction in death. There was not a significant reduction in MI, acute coronary syndrome, or, we were even surprised by this, stroke. It was a little bit down, but not significant. And that was a surprise, because of all the blood pressure-related phenomena, it should have been stroke. So this almost made it look like it was a heart failure trial as opposed to a blood pressure trial. And I can give you some reasons why that may be so, because remember, they were already on 2 medications. So what did we have to do to lower the blood pressure down to 120? We had to use intensive diuretics. I mean really intensive diuretics, and very, very high doses of renin-angiotensin inhibitors, both of which would target congestive heart failure. But nevertheless, the blood pressure still matters. But it wasn't free. There was adverse events. There was more hypotension. There was more syncope. Strangely enough, there wasn't more injurious falls. So there were greater falls, but they weren't injurious falls. Why? This population knew that if they even had a twinkle of lightheadedness, they were supposed to call us. So they already knew. They were hammered about this, and which is a good thing. So they did fall, but they didn't injure themselves. Probably because they caught themselves, they sat back a little bit faster, they slid down instead of going boom. And there was more electrolyte abnormalities, particularly hypokalemia. Why? We were using intensive diuretic therapy. And there was more acute renal injury, meaning the creatinines went up significantly in some of these individuals. Again, probably because of acute diuresis coupled with intensive renin-angiotensin system inhibition with ACE inhibitors or ARBs. But nevertheless, these did not affect the outcomes, which was dramatic and remarkable. I want to continue to emphasize that. And it was in all the populations that we pre-prescribed, particularly our older populations. And this is the one I want to highlight, because I do believe it should be incorporated into the guidelines. Actually, the older you were, the more effective lowering blood pressure was. It was not the converse. So if you were greater than 75 years of age, you had more efficacy, greater efficacy, than if you were under 75 years of age, but it wasn't significantly different between the two populations. But again, it bears true that we should be treating our elderly, and whatever that definition is, and our older populations as aggressively, perhaps if not more aggressively, if they can tolerate antihypertensive therapy, as opposed to our younger population. Interesting. So what are the caveats, and we'll move on. The caveats are, remember, if you're going to look at the evidence, you got to know the evidence. This was an intensive clinical trial setting with close monitoring. We could not reproduce this in our general medicine clinic. And they were virtually side by side. You went through the sprint door, or you went through just a regular clinic if you were a sprint subject. And the sprint, we were all over them. We had nurses, pharmacists, you name it, physicians, monitoring these individuals. This was a highly adherent, high-risk population, not the general population. The intensive group used 3 agents or more, and I've already mentioned the diuretics and the RAS inhibitors. Again, we talked about the piddly risk reductions. Even though the percent reduction was 25%, it was only 0.5% relative risk between the two groups. That's interesting. We should discuss that. Also, and this is the big one. The big one was, for some reason, I wasn't on the committee, we changed the way we measured blood pressures. We measured blood pressures by automated systems in a dimly lit room with no observer present. They were completely automated. The patient was put in a room and we walked out. It turns out that that is a game changer. It probably should be done in our clinical practice because it results in 10 to 20 millimeters of systolic blood pressures lower than traditional methods, or standard methods that other trials have used, which means that those goals of 138 and 120 might have been 150 and 130. So under traditional means. Don't know what to make of that, but that's the facts. Another trial at the same time was the HOPE-3 trial, which looked at intermediate cardiovascular risk patients and lowering blood pressure. And they determined, interestingly enough, there was no difference between lowering blood pressure in one group versus placebo group in patients with intermediate cardiovascular risk and not hypertension. So this is interesting data. This was a large multinational study not conducted in the United States. And more importantly, they demonstrated that it depended on your baseline systolic blood pressure. If your systolic blood pressure is greater than 143, you derive benefit from lowering blood pressure. Well, that just follows our other evidence that if you're greater than 140 systolic and you lower it, you're going to derive benefit. But if you're 131 to 143, you're in the middle. And actually, if your systolic blood pressure is 131 or less, you actually can derive harm. So that was interesting. Almost like the LDL cholesterol we talked about, maybe the higher the blood pressures, the more you derive benefit from blood pressure reduction in this pre-hypertensive or intensive treated modality, if you will. So that's interesting data. That data was available by the ACC-AHA Guidelines Committee. They incorporated it. However, I'll tell you how they incorporated it. What about patients with diabetes? Are they special? Are they a special population? And remember that the HOT trial that I told you, the magic number was 83 diastolic blood pressure for the general population, but it continued to be, the outcomes continued to be better the lower the diastolic blood pressure in the diabetic cohort. And there was a significant number of diabetics in this study, so this data is probably, and I'm just going to say is real. So diabetics do confer a greater benefit, if you will, at lower diastolic blood pressures than the general population. Remember, the general population, this would have plateaued here. You wouldn't have seen this further reduction. Well, we didn't see this further reduction. So those special populations may need to be carved out and looked at with a different lens, particularly our diabetics and our chronic renal disease patients. However, this study was in parallel to the JNC8 committee. The ACCORD trial did the exact same trial. They took type 2 diabetics, and they let the standard therapy was lower the blood pressure to less than 140. And the intensive treated group was lower the blood pressure to less than 120. And doesn't this look identical? The blood pressure levels were identical to SPRINT in this diabetic population, and yes, you can aggressively lower blood pressure in patients with diabetes. Unfortunately, it made no difference in the general outcome in our diabetics, whether you had intensive blood pressure reduction or not, of all outcomes combined, with the possible exception of stroke. Stroke was significantly reduced in the intensive treated diabetic population versus the standard treatment population, and that makes sense. Even though it was a small number of strokes, at least it's explainable scientifically because stroke being the most closely related target organ to blood pressure elevation. However, that was the ACCORD trial, and the ACCORD trial was complicated by a 2x2 table modality. They were also doing intensive glucose control, if you will. And intensive glucose control, remember, increased mortality. So it's a confounder. So what the ACCORD investigators did was they continued the trial, but only on an observational basis. The patients in ACCORD were asked, do you want to continue to be seen? And 90% of them said yes. And this is now called the ACCORDIAN follow-up trial. I thought that was pretty clever, ACCORD, ACCORDIAN. In any event, about 90% of patients continued to be observed. Now remember, the results were already known. There was no benefit of lowering blood pressure, so the physician stopped the blood pressure treatment, and then the blood pressures came back up. Now, however, though, about 10 years later, there was no decrease in stroke anymore between the two groups. It went away because, remember, the blood pressures would go back up in the intensive treated group because we're appropriate practitioners. If it didn't make a difference, take the medications away. But now the stroke difference disappeared, implying that the initial difference in stroke was real. But more importantly, there was an interaction between blood pressure and glycemia. Because glycemic control worsened events, blood pressure control may actually have improved events if you took glycemic control out of the equation, the intensive versus standard glucose control groups. Now you saw a significant 21% decrease in cardiovascular risks. And this took many, many more years to become significant. So yes, in our diabetic population, intensive lowering of blood pressure is probably better. And this was all new data from those previous guidelines committees. So, armed with all that information, what did this committee decide? They looked at 4 different areas: home or out-of-office monitoring of blood pressure, obviously targets, which we're going to talk about mostly. Are there any differences between classes and/or harm? And what about monotherapy versus dual therapy, combination therapy? This was the major controversy. Armed with now this new information from Sprint, et cetera, the committee decided to reclassify hypertension. And this was the game changer, at least for me. The pre-hypertension category went away. And now the ACC-AHA committee is calling stage 1 hypertension the pre-hypertension, the pre-hypertension category. That means that you're normal if you're 120 over 80 or less. You're elevated if you're in the 120s and less than 80. That's interesting. Now you're elevated blood pressure in the 120s. Somebody comes in Monday morning to your office and they're 122. By this classification, they have elevated blood pressure. Wow. But I don't know. But more importantly, this is the game changer. If your blood pressure is greater than 130 systolic, or greater than 80 systolic, you now have hypertension. You have stage 1 hypertension, and you would be diagnosed as having hypertension. And now, what do you do with it? The old stage 1, greater than 140 over 90, now becomes stage 2. So basically, the pre-hypertensive range from JNC 7 and on was taken out and replaced by, you got hypertension. What are the implications of this? What about the implications for treatment? What about the insurance implications? What about just psychological implications of giving somebody a diagnosis? Monday morning, if someone's 132 over 80, they have hypertension? Yes, by this chart. I'm being dramatic on purpose because this requires drama. What about out-of-office blood pressures? And this is, I want you to take this home message. Do them. Absolutely do them. Either ambulatory blood pressure monitoring or home blood pressure monitoring. Again, they're critical. We could have another lecture on this next year as to why they're critical. But I can tell you they're critical. No longer can we rely on the office blood pressure. Matter of fact, we probably should stop taking the blood pressure in the office unless you're going to take it by the methodology of Sprint in a quiet, dimly lit, closed room, automated with no observer. What about the treatment of hypertension? Well, now that 130 over 80 and greater is hypertension, what's the treatment recommendations? The committee had to do some fancy tap dancing on this one. Do you recommend pharmacologic treatment for everybody when there's very little evidence to suggest that? But now they've called it hypertension, and the answer is the way they got around that was use blood pressure lowering medications at blood pressures greater than 130 over 80 in that second category. In that category with already if they have cardiovascular disease, or those at high cardiovascular risk, greater than 10%, and your target should be less than 130 over 80. So you should pharmacologically treat, according to the new guidelines, individuals 132 over 82 if they're in this high-risk category. And by the way, the risk calculator was the standard AHA risk calculator that Dr. Piziak asked us about previously. And there's some concerns about that calculator, but that's the calculator they used. On the other hand, that would be about 5% of the patients on average. For the other individuals, start intensive lifestyle modification to achieve a blood pressure of less than 130/80. Remember, the treatment of mild hypertension study proved you could do it, but it has to be very, very intensive. And I don't know if we can do this in our practices, and I'll come back to this. What about the traditional blood pressure? Now stage 2, which was our previous hypertension. Yes, lower the blood pressure with blood pressures greater than 140/90 pharmacologically in everybody. And the target now, though, is not less than 140/90, it's less than 130/80. So the threshold remained the same. The target, though, was more specifically reduced to 130/80 or less. And finally, they did recommend, for stage 2 hypertension, start with a single agent, but you can use combination therapy, as we discussed a few days ago, if the blood pressure was greater than 160/100, or you were 20/10 millimeters of mercury or greater from the goal that you set a priori on the initial visit. And we talked about maybe moving this up to here. What about our older populations? No difference anymore. Irregardless of age, if they're healthy, ambulatory, non-institutionalized, the goal is the same. Hypertension is a systolic blood pressure greater than 130, and the treatment goal is less than 130. This is a dramatic change from JNC8, which was 150/90. Even from JNC7, this is a dramatic change. If you're comorbid, et cetera, use your clinical judgment. That makes sense. And again, use medications that would increase adherence. And use team-based care. We talked about the medical home in one of our discussions. So take this chart home. It's in your packet. We summarized this for you from the American Society of Hypertension. And here's the new chart based on the new guidelines. And again, you can see that in general, it's 130/80, goal less than 130/80. The high-risk populations are all the same, except for secondary stroke prevention. We know that you probably should start with a higher systolic. But as you can see, the goals are absolutely identical. And again, independent of age. So you got to take a step back and say, what the heck? I mean, what am I doing now? How have I made this so complicated for something that was reasonably straightforward? And there was a response, and the response was vigorous, as you might imagine. There was vigorous supporters. They generally tended to be individuals on the guidelines committee, or the American Heart Association, or the American College of Cardiology. I don't blame them for that. They were the sponsors, right? And they're outstanding colleagues of mine. But there was editorials written after editorial after editorial. One of my co-workers, Ray Townsend, and Dr. Cohen from Penn wrote, what in the world? Both too much and not enough of a good thing, questioning some aspects of the guidelines. The American Academy of Family Physicians flatly said, no, we're not going to endorse the recommendations because they use less evidence-based medicine. The American College of Physicians that you just heard from Dr. Wagner, so now the AAFP and the ACP, the two largest primary care organizations in the country, the ACP did not endorse these recommendations. And that's really, that saddens me only because we don't need this controversy. This is not simple, but it's reasonably easier than this. If you follow these guidelines, one meta-analysis suggests that you will increase a lot of things, but you'll decrease a lot of really good things. But that's only on a piece of paper. So what are the implications? And we'll finish. On a health system, population, and practice, what are the implications? Well, number one, if we now call 130/80 stage and greater stage 1 hypertension, the prevalence of hypertension dramatically increases. It's estimated now to be almost 50% of all Americans. We'll be running around with a tag, a label, I'm hypertensive. Okay, that's just what it is. But given the difficulty with adhering to intensive lifestyle modification, which was the treatment recommendation in the vast majority of these stage 1 hypertensive individuals, unless you're going to do it intensively, we cannot, I don't believe we can achieve that in our practices without significant modification and increased resources at my institution. What's going to be the fallback position? We are going to our human nature is to tend to use pharmacologic agents. So my big concern is the vast majority of these individuals labeled hypertension will end up on pharmacologic therapy where there's not evidence for efficacy. It might be, I might want to wish it, but there's not evidence. And that will just be human nature. And significantly, we have to change the way we measure blood pressures in the office. That's labor intensive, et cetera, but we can do that. I strongly recommend we do that. And to increase our out-of-office blood pressure monitoring. If we're going to follow these guidelines, you've got to follow the guidelines. What about on the patient? Well, number one, it's going to increase not only our education, we're here today being educated, and I've been educated immensely during this week, but it's going to increase our time for patient education, to explain it to them. The good, the bads, the uglies, the whys, the wholes, what's it based on. While fixed dose combination therapy may be helpful in terms of adherence, et cetera, there's going to be a significant increase in medication use and polypharmacy. Only because of that stage 1 group now, I truly believe is likely to get pharmacologic therapy when lifestyle modification is not adequate or doesn't achieve the goal. It's just human nature. And finally, if not closely followed, adverse effects may increase. We saw adverse effects in the SPRINT study, but they were mitigated by intense monitoring and a very close family, if you will. If we tried this in my general population in my general medicine clinic that Dr. Wagner and I attend in, I don't know what's going to happen. Clearly, I would wish not, but I think injurious falls may increase. Not just falls. And finally, it adds the complexity of out-of-office blood pressures, but this is a good thing. So what should we do moving forward? Where are we and where are we going? The ACC-AHA guidelines are highly dependent on the SPRINT results, which is a high-risk, intensely motivated, older population. May not fit all of our other patients that we're seeing. And observational evidence. I've coined this term, and some people like it, and some people want to shoot me. Maybe we should walk before we sprint. By that I mean, let's slow down. Let's take a step backwards. Let's incorporate in the guidelines what makes sense and what we could all agree on. And let's take a step back and maybe take a wait-and-see approach on other components of the guidelines. Let's follow the debate, and as I suggest, let's implement what makes sense. Well, what is that? I strongly think we should go back to JNC 7 until this all settles out. Consider the treatment threshold and control levels on most of our patients to still be 140/90 or greater, and less than 140/90 in all ages. And now that is diametrically different than JNC 8, which recommended 150/90. So I think we should be treating all ages with these guidelines. That's JNC 7. And those, though, at that high-risk population, yes, strive for 140/80 in all individuals, but especially in those with chronic kidney disease, high cardiovascular risk, present cardiovascular disease, and or CKD, chronic kidney disease. Aggressive lifestyle modification is still appropriate. We need to figure a way to increase our out-of-office blood pressures, as we'll discuss tomorrow, or actually later today. Standardized and formulary algorithms can help, and T-based care. And most controversial, and I just presented this at a major institution's medical grand rounds, and this was probably the most controversial of my slides. Maybe we should reconsider the new hypertension classification. Maybe we should take a mulligan. Those of us who play golf, or this Kia was just a golf paradise, by the way. We've been in here instead of the golf course. We should reverse that, Dr. Piziak, but that's okay. In any event, maybe we should take a step back and call for a mulligan and look at that classification again. I don't know if that'll be done. Clearly, the ACC and AHA have said no. This is our guidelines, and we're going to stick with them for the present. That's fine, and they may be right. I just don't know. We've come a long way. Dr. Wagner showed the echo machine, $5,000 billion echo machine that took up half the room. I asked my medical students, and I teach pharmacology at USC, and I asked them, what is this? And 3 of them raised their hand and said, Dr. DiPette, it's a transporter. I said, I give up. I can't be here anymore. So what is it? It's an EKG. It's the original EKG machine. Remember that this is a medical student. There was no consent in those days. And the student says, has been told by the professor, just sit right here, Joe or Don, and put your hands in these buckets of water. And I'm going to pull the switch. And let's see what happens. The good news is, hopefully, electricity was going this way instead of that way. I thank you very, very much for having me.
Yeah. Questions?
Yes, Ronnie.
So, do many of you have elderly patients who have blood pressures of like 150/76, who have low diastolics and high systolics? Right, we all do that. And you put them on your blood pressure regimen and try to get them to less than 80, 130/80.
Well, they're systolic at least to less than 140, possibly even less than 130.
Right.
Yep.
And so they fall over when they stand up because their
Yep.
blood pressure turns into 140/52.
Sure.
What do you do about them?
Well, you don't
Do you
lower
have
the-
those guys? How many of you have those?
Oh,
we all
everybody
have
has. I've got those. You don't lower the blood pressure, Ronnie. You only can do what you can do. If you, obviously, it's a myth. The way you lower blood pressure can possibly be changed. Possibly lower doses, go slower, and maybe the fixed dose combination strategy where you use more drugs but at lower doses and lower that blood pressure gradually. But yes, our older I'm going to say older population because I don't know the definition of elderly, and obviously it gets older as long as I live. I think that all you can do is just do not make them symptomatic for sure. But do it slowly. But the data still is we should try. But a lot of patient education that this may, Mrs. Smith, Mr. Jones, this may lower your blood pressure. Be careful when you get out of bed. Be careful from the seat. Take your time. Sit there for a minute or so. Get up. But the data does show most of our older population tolerates very well lowering systolic blood pressure. The diastolic blood pressure is a little more controversial. Because you're talking about the U-shaped curve, where at lower diastolic blood pressures, mortality actually goes up. But those are at extremely low systolic blood pressures, certainly less than 70, maybe even less than 60, and only in those individuals with pre-existing coronary disease. So I'm going to just say, if we've made it to that age, probably our coronaries they're not okay, but somehow they've got us there. But the data does show, and the evidence does show, you can lower the blood pressure in the elderly. Any bit that you lower, you may not have to achieve these goals, but any degree that you lower the systolic blood pressure in our older population is actually, they derive more benefit than if you did it in the young. That's what it shows. Yeah.
Here we got one over here.
This may not really be that important, but for
everything's important.
For cholesterol guidelines, high risk is cardiovascular risk is 7.5% or higher, 10-year risk, and then for blood pressure it's 10%.
Right.
How do they differentiate the two?
They're not talking to one another for sure. But remember, the pathophysiology of those two diseases don't have to be absolutely identical. So you can have different guidelines for hypercholesterolemia to treat based on the evidence in hypercholesterolemic patients versus hypertensive patients with blood pressure reduction. So that's how I would explain it. So if you have a hypertensive individual without hypercholesterolemia, use those risks. But I would use the lower risk ones for what the therapy that you're going to institute. So if you're considering statins or statins plus, I would use the guidelines from our colleagues from the ACC, AHA, ADA, et cetera, regarding what risk you would use in those individuals. If you're specifically targeting antihypertensive therapy, I would use the current guidelines and those risk levels and the calculators that are recommended. Yeah, I can justify them being different. I would love them to be the same.
It's a shame, yeah. All right, thanks.
Other questions?
Well, thank you very much again.
When's the next JHC coming out?
Oh, there won't be.
They gave up.
That was I didn't want to get into this because this is politics, but this is a very, very good question. What happened to JNC8 it's public knowledge. I'm not giving any, dirty laundry. The NIH sponsored all the JNC7 program from its inception all the way through JNC7, and they consolidated and consigned and charged the JNC8 committee. That was about 10 years ago, and they were meeting. At the 11th hour, when they were finishing their recommendations, JNC8, the NIH decided to get out of the guideline business entirely. So they just said, we're going to get out of the guideline business. Well, it would have been nice if they had let the JNC8 finish, but they didn't. They asked the ACC-AHA, since they were already doing the cholesterol guidelines, to come in and do the hypertension guidelines. When the AHA-ACC asked to have representation on the JNC8 committee, since it was at the 12th hour, they already had their recommendations already done, the JNC8 committee said no. We've done all of this work, and we don't want to restart with new people and new ideas and new groups, if you will. You could argue, was that the right decision or the wrong decision, but that was their decision. At that time, the NIH withdrew their support from JNC8, and actually JNC8 got the report published, but it's under the JNC8 group. It's not the JNC8 committee, so that was never solidified by the NIH, and that was a political conundrum. Then the ACC immediately formed their group. Since they weren't invited into JNC8, they immediately formed their guideline committee and came out with the ACC, AHA guidelines that you see from 2017. So that's also a conundrum. Yeah, that makes me sad. As one that was not on either of the guideline committees, as an interested observer, that saddens me as well, but that's what happened. So there'll be no more JNCs. It'll be ACC, AHA, or other organizations, just like we have now for hypercholesterolemia, cancer, et cetera. There's no unifying group.
I've got one question back here.
Thanks for the lecture.
You're welcome.
I'm starting to see a lot of patients in my clinic, heart failure patients, with the implantable MEMS device. And I know in the Champion trial it showed decreased hospitalizations and things like
Yes.
that. Are you starting to see that these patients we're trying to favor for a lower PA pressure, we're starting to favor them to be a little bit more drier? And
Yes.
then, as far as what you're seeing, is that leading to syncope and things like that?
I don't take care of this population, but we are a large center in Columbia. I have hundreds of patients on obviously intra. What he's talking about is now we can measure real-time with an implantable device pulmonary artery pressures, in addition to everything else, to guide therapy for congestive heart failure, not blood pressure, but congestive heart failure. So you're absolutely correct. The data is astounding in terms of improvement in readmission rates, et cetera. It's not long enough to know about outcomes, death, mortality, et cetera. We're not seeing more syncope, et cetera, mostly because, number one, that's on the preload side. Sure. So you're monitoring the right side, right. And you're aggressively targeting preload. Some of the agents affect afterload, but not as much as if you were truly trying to lower the arterial pressure, and you would get more syncope.
Okay.
The guidelines are in congestive heart failure on the arterial side, less than 130/80, clear cut, hands down. If you've got I don't see many of those patients. I mean, I see heart failure patients, but usually they have low blood pressures.
Right.
But if you have a heart failure patient with high blood pressures, greater than 130/80, absolutely lower it with arterial medications on the left side while you're still following PA pressures and doing what you need to do to decrease preload and decrease PA pressures.
Gotcha.
Yeah.
Thank you.
Very, very good question. Thank you very much for that.
Anybody else?